As a breast cancer surgeon, several years ago with my team in New York City, I helped develop a set of protocols to help expedite patient return to functionality. Or, a lot of my patients wanted to get back to work quicker. And, as a side effect of that, what we ended up doing was doing a much better job managing patients' pain by getting them back to their normal life. One of the ways that we did that was by intervening early. So we had a good conversation with patients before surgery to talk to them about expectations for their pain, what was normal, what's not normal, have them buy some non-opioid medications to have at home for after surgery so that they're prepared, so they have a plan. And so then after surgery, we have them alternate acetaminophen and ibuprofen, which are the over-the-counter generic non-opioid medications. And then if they have pain outside of that, then we're able to give them an opioid prescription if they need it. But what we found was that most patients actually didn't need opioids. And this actually helped expedite their return to normal life. I even have patients who I would do their surgery on Friday, and they would tell me, wow, Dr. Rojas, I felt so good. I was entertaining over the weekend. And I was like, well, you want to make sure you take it easy, but we're definitely glad that your pain was well controlled. Enhanced recovery after surgery protocols, also known as ERAS, come from the ERAS Society, which has released several sets of guidelines depending on which surgical procedure that you're having. And then there's various ERAS-like protocols that different societies and institutions have adopted that have similar concepts, meaning, attacking pain in different ways, increasing preoperative education, and giving multimodal analgesia, which is non-opioids plus opioid pain management after surgery. So it's kind of a blanket term that spans different surgical subspecialties, including not only cancer surgery, which is the space where I work, but also gynecologic surgery, orthopedic surgery, neurosurgery, et cetera. What we've done is actually offer patients an opioid prescription based on what their requirement for opioids was while they're in the hospital. So whereas a couple of years ago, we were just giving a blanket number of pills that we gave to everyone, now we're kind of individualizing that recommendation based on how their pain control is while they're in the hospital. The other benefit now is that we can e-prescribe opioids. So a lot of times when you speak to your doctor, they'll give you a phone number to call in case of an issue after surgery. And oftentimes they can send a prescription electronically. Where I trained in New York City, where I started my career, and in Florida, where I am now, we're able to do that, which actually makes it a lot easier in the event that patients have uncontrolled pain. This is actually a really great point because a lot of, when we first came out with these protocols, that was a big concern. Well, if you're not treating pain, is that really helping the patient? We actually looked at patients' pain scores, and using this multimodal approach where we treat patients' pain before, during, and after surgery with several different types of non-opioid medications, they actually had lower pain scores than the group of patients that received traditional opioid-based perioperative care. So we actually found that by tackling pain in this preventive way, including blocks, non-opioid medications, anti-inflammatory, good preoperative education where we help decrease your anxiety before surgery, that actually makes it so you don't need opioids. But we don't want to leave pain untreated because we know that actually has negative effects. So leaving pain untreated increases your stress response, can make healing more challenging, and just make it for a miserable post-operative recovery. So this really highlights the importance of setting expectations with your physician before surgery and having this conversation about what's my plan, what are you trying, what interventions do you have to decrease my pain after surgery, and what do I do if I'm still pretty uncomfortable and I'm worried about pain. Addressing stigma related to opioids is super important. In the middle of this opioid epidemic, the COVID pandemic has really worsened where we are with that. In the last several years prior to the opioid pandemic, the number of opioid deaths in the United States is actually decreasing. But early reports show that last year they actually increased by 30%. And we had over 100,000 people die from drug overdose last year. And so it is a hot topic and one that we should definitely navigate carefully. I would encourage patients to try not to worry about the stigma between them and their physician and really ask for what they need. But setting up the expectation prior to surgery really kind of puts a plan in place to kind of decrease that awkwardness or any concerns they may have about asking for medication. Sometimes this may mean that your surgeon prescribes you only a certain number of days, like 1 or 2 days. And that's because we're really trying to decrease the large quantity of opioids that we were prescribing before that often just went unused and unlocked in people's medicine cabinets and then were diverted and then used for other purposes. These drugs do expire, so we also encourage patients to turn their unused opioid prescriptions back in. But there are a lot of misconceptions, and we're learning more about this now, different provider perspectives on treating pain, not just between men and women, but also between individuals of different races. And we've really probably undertreated patients from different groups, depending on where they're from, what they look like, what kind of medical problems that they have. And that's something that we're really drawing a lot more attention now so that we can address these issues and prevent them from happening. Women can be involved in the decision-making process from the preoperative visit. Actually, now that I think about it, probably even before that, you have a choice about what surgeon you're going to go to. You could look your surgeon up online. You can see what kind of talks they've given, what kind of papers they've published. Is one of their research interests ERAS protocols or opioid-sparing techniques? And patients are really empowered today with the wealth of information that's online to be able to select their surgeons. So oftentimes, if you meet with a surgeon and you talk to them about their pain management protocol and maybe you want to get a second opinion, that's okay. And I actually encourage patients to do second opinions. As a breast cancer surgeon, I see second opinions of my colleagues. I do first opinions, third opinions. Oftentimes that's a way for patients to really feel solid in their decision-making, like they're making the right choice. But also you want to have a team that you really gel with, that meets your expectations and you feel like they're addressing your concerns, which may be addressing pain after surgery. Some important questions that women can ask their surgeons are, what are we going to be doing to decrease the pain after surgery? So are there any techniques that you employ during the procedure, such as blocks? A nerve block is where the surgeon injects some long-acting numbing medication to some critical nerves that supply the area where the surgery is performed. And these can be done really easily. They only add about a minute to the procedure when done by the surgeon. Some surgeons also ask their anesthesia colleagues to give them a hand, and we can do these blocks under ultrasound guidance all while you're asleep. This can be done before we even make the incision. And so it actually decreases pain before it even starts. And so ask your surgeon if they're going to be doing any nerve blocks for you, or if any of their colleagues are going to be doing a nerve block, either while you're in the preoperative holding area or while you're asleep. And then also ask them about anti-inflammatory medications. There's a myth that a class of medications called NSAIDs, or non-steroid anti-inflammatory drugs, increases the risk of bleeding after surgery. But more recent research has shown us that's probably not the case. And so these drugs, which include ibuprofen and ketorolac, which are the generic forms, can be really helpful in decreasing the inflammation after surgery, which is a critical component of pain. So oftentimes, double check with your doctor, make sure that they're fine with you starting these after surgery, which would be like ibuprofen, which is over the counter, which you can alternate with acetaminophen, which is a non-NSAID, and really kind of tackle the pain in two different ways. But it's good to have this discussion beforehand so that you can be a good patient, but you also let your surgeon know that you want anything to be done that can decrease your pain. Specific to breast cancer surgery or breast reconstructive surgery or breast plastic surgery, if a patient's having a smaller procedure like a lumpectomy, which is where we only remove the tumor and a normal rim of tissue around it, maybe with a small incision in the underarm, with multimodal analgesia, which is giving those non-opioid anti-inflammatory medications with blocks prior to surgery, oftentimes they don't need any opioids for these smaller procedures. The incision's smaller and they can go back to work within a week, maybe even sooner. The larger procedures like mastectomy, so depending on whether they're having a mastectomy, which is complete removal of the breast with reconstruction or without, patients who have a mastectomy without reconstruction, oftentimes they can go home from surgery the same day, as long as they don't have any other medical conditions that we're keeping an eye on. We can, after removing the breast during the surgery, we can do what's called a PEX block, which is where we inject long-acting medication into the pectoralis muscle, which is actually this chest wall muscle right here. And then what I also do is like a peripheral nerve block, which is where I kind of make a big square around the chest and numb the entire area so that the patients really have minimal pain after surgery. And so if you're having a mastectomy without reconstruction, you may also not need opioids after that as well. But it's really a case by case basis and how aggressive your surgery was, how many lymph nodes your surgeon had to remove from the underarm, et cetera. And then for patients who have reconstruction, oftentimes they are a little bit more uncomfortable after surgery because we're placing an implant, a tissue expander, or we're removing tissue from another part of their body and placing it onto the chest. And so oftentimes these patients do require opioids, although not a lot, not what we used to think in comparison to the days when we didn't utilize multimodal analgesia. So, the guidelines say for lumpectomy patients, probably less than 5 pills is appropriate for an opioid. Mastectomy, probably around less than 10. And then mastectomy with reconstruction, probably around 10 pills is appropriate. But like I said before, a lot of patients don't even need that when we're using these techniques. Previously, we knew that opioids had negative effects such as nausea, decreasing your gut motility, like increasing constipation. It can also make you sleepy and, sedated. But now we're learning more outside of their addictive potential. We're learning more about how opioids may increase the inflammatory response in your body. And what we're worried about is how that may impact patients who have cancer. And so there's some preliminary studies that have been done that actually show that patients on chronic opioids may have worse cancer outcomes. And within the lab, like looking at mouse models, it looks like opioids might increase the risk of breast cancer leaving the breast and going to another part of the body or metastasizing. And so this is really compelling information and something we need to learn more about and do more studies to figure out exactly why this happens. But it's actually the focus of my research, looking at how opioids impact the gut microbiome and how that may impact the immune system, which can impact cancer outcomes. So, opioids may have more negative effects than we even really know about now. And so that's why I just encourage everyone to be really judicious about their use and to ask their doctor about those multimodal analgesia strategies.